I like that idea. The interesting about the dual combined kidney. I always struggle with this because so many of these patients, once you give them a liver, their kidney just gets better. So like the 30 threshold seems like how do you choose those patients?
It's definitely an evolving area, and what I would like to see is more standardization because you can go to a cystatin C, which is often lower than the creatinine based formula. And right now, the rules are written so that you can sort of cherry pick your GFR. Now, the other challenging thing and evolving thing in this space is livers are very well preserved by this technology called normothermic machine perfusion, where they can take a liver from a donor, put it on the pump, and then has basically we've been salvaging a lot of organs that we would have otherwise not been able to use. And it doesn't work quite that way for the kidneys. And so we didn't expand our kidney pool in the same way we expanded our liver pool with this technology, for example. So a lot of times they can get a liver for some of these patients, but not a kidney. They know it's not going to come viable if they take the liver. And so that's another complicated decision process in this approach. I mean, it's certainly lousy when you have persistent dialysis after transplant, for example, or wind up with some supreme level of CKD, and that limits your tacrolimus use, for example, after transplant. But at the same time, most of my clinic is managing that CKD. So I think it is an evolving area, and you'll see the policies probably continue to evolve. It's an area I'm trying to do research in as well for that exact reason.
Very good. Question here. What about PD and liver cirrhosis patients? That's also a tough one. Oh my God.
Yeah, I get this question a lot, and I end up taking the slides out because there's really not a ton of evidence on it. A couple of nice case series, but the reality is the practical limitations to doing PD in this population is very challenging. I've done it once or twice, I would say with mixed results. I think there's some theoretical benefits, like these patients often have concurrent ascites, so then you can drain the ascites and prevent the paracentesis need and maybe manage their volume a little more effectively. And obviously, hemodynamically, it's a favorable modality compared to hemo, which these patients tend to be hypotensive and vasoplegic, so they're not going to tolerate hemo all that well. But on the other side, there's increased risk of infection. There's the surgical risk of putting a catheter inside a tense abdomen with ascites that may or not take. And then you're losing albumin in a patient that's already hypoalbuminemic from poor synthetic function, so their nutritional status is potentially further compromised. The reality is, at least we don't have here in Boston like the infrastructure available to take a large amount of these patients. I have one patient I'm trying to get on right now who can't stay out of the hospital long enough to get the PD catheter placed, and but he's struggling on hemodialysis with hypotension and volume overload. So it's really a no-win situation that I think in other areas may have had better success, but I personally haven't been able to get a ton of patients on to try that.
Very good. Dr. Glassek, would you what would you do with somebody who has a minimal response to rituximab in FSGS, but does have adequately suppressed CD19/20? Would you consider still trying obinutuzumab?
Thanks for that great question. And the answer is yes, because peripheral B cell depletion does not measure the depth of the tissue depletion. And in patients who have treated with RTX and have a partial remission, but the depletion of B cells is complete, I still would think about using obinutuzumab, particularly if the patient relapses. Obinutuzumab produces the same degree of peripheral B cell depletion, but a much greater tissue depletion. And it may be that the tissue depletion is more important for the lasting and deep remissions. Yes, I think obinutuzumab is a potential treatment for rituximab failures.
That's really interesting. We were having a kind of a mini argument, myself and one of my fellows yesterday in clinic, about this, because it turns out in one of their other clinics, they're using rituximab still as first line for lupus and, just monitoring the B cell responses. But it was, this kind of gives another line in that argument that maybe obinutuzumab is better for other reasons. It's not just the peripheral B cells, like you said.
Well, of course, neither rituximab or obinutuzumab is approved by the FDA for a treatment of primary FSGS. There is no drug. There is no drug for approval, so everything is off-label. You have a lot of difficulty with individual insurance coverages. But you must remember that obinutuzumab has a good track record of safety. It's no more expensive and maybe a little less expensive than rituximab. And it certainly has a very good track record in rituximab resistant patients, for example, membranous nephropathy and in lupus. Now, we don't have the final analysis with a randomized controlled trial, but all of the data, observational, is pointing in that direction.
All right. So we will leave it at that. And thank you very much to our presenters this morning. That was absolutely fantastic. Thank you to everyone for your attention and for your questions. And I'm sorry for not getting through all the questions. There were a lot of questions today, which is not surprising because these are really interesting and important topics. We will come back again at 1:55 for the pathophysiology of acute kidney injury. And Dr. Allegretti will be back at around about 3 to talk about ICU and CRT. And I will see you all at about 5:30 for some talk on diabetic kidney disease. So enjoy your lunch and we'll see you in a while.
Okay. Thank you very much. Bye-bye.